group's oral presentation of a reverse case study, we will be doing the endocrine system with a specific focus on diabetes type 2. I will be introducing our patient and her current health condition, and my peers will follow on with the rest of the presentation. Patient data: name, Mary Jane, sex, female, date of birth, 12th of the 8th, 1950. Age, 65 years old. Height, 165 centimeters. Weight, 90 kilos. Residency, 24 Byron Drive. Admission date, 1st of the 3rd, 2016, 3 days ago. Vital signs: heart rate, 88 beats per minute. Blood pressure, 155/90. Respiratory rate, 16 breaths per minute. O2 saturation, 99% with oxygen. Temperature, 36.5 degrees. Blood glucose level, 8 millimoles per litre. Background: Mrs. Jane worked in IT for a finance company before recently retiring. She used to live with her husband, but he has passed away quite recently, roughly 6 months ago. She was taken to hospital by her only daughter, who was worried about her mother's deteriorating health. She was never a physically active person, but all sorts of exercises stopped when her husband passed away. Past health: diabetes type 2, hypertension, depression, high cholesterol, and has had a fat tissue removed from her shoulder. Current health status: diabetes type 2, hypertension, depression, high cholesterol, and pressure injuries developing on her sacrum, right and left heel. She was also bruised slightly on her left arm and hip after slipping whilst going to the toilet on her first night. The pain described in the bruised areas is around a 3 out of 10 and with a constant dull throb. She has also had a loss of appetite in the last few days. Behaviour: Mary Jane is quiet and introverted, doesn't initiate conversation with other residents or the nurse unless she really needs something. She keeps asking to leave and go home. She constantly refuses to have her blood sugar levels taken and becomes aggressive if asked constantly. She also complains about the food being too plain. Other observations: she is constantly refusing to have her blood glucose levels taken, and as a result, interventions are hard. This is due to her fear of needles and sharp objects, and this makes it hard for us as nurses to accurately document her blood sugar levels. She is classed as a high falls risk, as she had fallen over late at night. She has developing pressure sores on her sacrum and both heels on her foot, and this results in pain and her staying in her bed. She has had a low output of urine in the past few days, as well as lack of appetite, and has been put on a fluid balance chart. She has also complained of difficulty of breathing, hence O2 saturation. She is due for a review with the doctor tomorrow, and her daughter will be visiting on the day after. Before we continue with the presentation, here are a few demographics related to diabetes. 1 in 20 Australian adults, so 5%, have had diabetes in 2011 and 2012. 900,000 hospitalizations in 2013 and 2014, where diabetes was the principal and/or additional diagnosis. 1 in 10 Australian deaths in 2012 recorded diabetes as an underlying or associated cause of death. Australian Aboriginals and Torres Strait Islanders have a 3 times higher death rate with diabetes than compared with non-Indigenous Australians. Diabetes death rates in the lower socioeconomic background is 2 times as high, with the highest in comparison.
Everyone, I'm Krishna. Today I'll be talking about pathophysiology of diabetes type 2. First of all, let's talk about what endocrine system is. According to Miro, endocrine system is a body system that regulates the functioning of body using chemical messengers known as hormones. These hormones travel through bloodstream and reach target tissue and bind with receptors to initiate a response. There are many endocrine glands such as pituitary, thyroid, parathyroid, pancreas, adrenal, and among them malfunctioning of pancreas leads to diabetes type 2. Out of all diseases and disruption in endocrine system, diabetes is known to be one of the most common conditions. There are 2 main types of diabetes, type 1 and type 2. Type 1 is an autoimmune condition in which body's immune system is activated to destroy insulin-producing pancreatic beta cells, so there is no insulin produced in the body. Type 2 diabetes is defined as a progressive condition in which body becomes resistant to the effect of insulin and loses the capacity to produce enough insulin in the pancreas. Type 2 diabetes is a metabolic disorder characterized by high blood sugar level. Classic symptoms include increased thirst, increased hunger, frequent urination. And the complications of diabetes type 2 includes diabetic retinopathy. Increased blood glucose level in the capillaries in our eye causes retinopathy. And obesity increases workload on heart by increasing area to pump blood, and excess fat accumulation in blood results in narrowing of the arteries, hence increases the probability of having hypertension, heart attack, and kidney failure. Increased fat and sugar in blood causes metabolic disturbances, increased vascular resistance to blood flow, causing slow wound healing and foot injuries and infection. Family history is proven to be strongly related to the risk of diabetes type 2, which is why assessing family history is important for nurses and healthcare staff to have an insight in the etiology of the diabetes type 2. Let's move on to how normal metabolism of a fat and glucose work in a normal cell. Fats and carbohydrates are digested and they reach bloodstream. Glucose gets to the pancreas along with calcium, which activates the beta cells to produce insulin. Insulin, glucose, and fats reach cells of our body via blood. And 4 types of proteins work together to metabolize fats and sugar. CAPN10 protein breaks down fat, ENPP1 carries insulin into the cell, IRS receives and phosphorylates insulin, GLUT4 phosphorylates the insulin, and then it carries that phosphorylated insulin and activates itself to let the glucose get into the cell. Once inside the cell, glucose molecules combine to form glycogen. Some glucose molecules gain electron and convert into pyruvates and metabolize to produce energy in mitochondria via Krebs cycle. In normal condition, glucose metabolism is regulated by feedback mechanism including beta cells and insulin sensitive tissue, in which insulin sensitivity affects the magnitude of the action of beta cells. If insulin resistance is present, beta cells increase insulin output to maintain normal blood sugar level. The problem arises when beta cells cannot compensate the insulin resistance and the blood glucose rises, leading to type 2 diabetes. So what exactly causes type 2 diabetes? So first reason is mutation of gene that produces IRS protein, which synthesizes defective IRS protein, and the defective IRS does not phosphorylate insulin, which leads to accumulation of glucose in the extracellular space and increased blood glucose level. The second reason is mutation of insulin receptor ENPP1. Defective ENPP1 cannot let the insulin get inside the cell, which causes the accumulation of glucose and insulin in the extracellular space and increases blood glucose level. It is also known as insulin resistance. And the third reason is mutation of GLUT4. Defective GLUT4 does not transport glucose into the cell, leading to accumulation of glucose in extracellular space and increases blood glucose level. And the fourth reason is excess fat. CAPN10 cannot break down all of the fat. Then fat accumulates in the extracellular space, obstructing the channels of ENPP1 and GLUT4, which leads to the accumulation of glucose, insulin, and fat in extracellular space and increases blood glucose level. This is caused due to the poor lifestyle choices like sedentary lifestyle and eating too much fat. Now we have understood the pathophysiology of disease. My friends will explain how Mary Jane could manage it properly.
Thanks Krishna for telling us about the pathophysiology of diabetes. I'm Tyler. I'm going to tell you about the management plan for diabetes type 2. There are 4 major interventions. First is patient education, second is dietary, third is glucose monitoring, and last but not least is insulin therapy. First intervention, patient education. Patient education can help the diabetes patient to improve the knowledge related to the health status in order to facilitate and support patient diabetes self-care. As nurses, we can focus on influencing the patients to live a healthy life by teaching patients to have a controlled diet, possible adverse effect of the medication, prevention strategies of hyperglycemia or hypoglycemia, healthy habit like exercises, also the awareness and management of possible long-term conditions of diabetes, such as diabetic retinopathy, kidney disease, diabetic neuropathy. Diabetes is a chronic disease. Patient education must not only include the current needs, but also needs to mention about the issues that may likely to arise at different stages of diabetes. The second intervention is diet. Nurses can help patients to manage their symptoms through diet by acknowledging the patient's condition, then report to a dietitian to create a personalized meal plan that cuts off the unnecessary amount of fat and sugar, but still ensure appropriate nutrient supplies. An ideal diet should include the following: eat regularly and spread to small meals throughout the day. The diet must be low in fat, in particular saturated fat. If the person has medications, they need to have snacks between meals. It is important to balance the amount of food intake with the amount of energy burned through physical activities of exercise. Limiting food with high energy along with healthy eating and regular exercise will help the patient to maintain the blood glucose level at normal level, reduce blood fat, and maintain healthy body weight. Fats have the highest energy content of all food. Eating fat can make the patient put on weight. Therefore, as a nurse, we must be cautious about the fat content in the patient's meal. Carbohydrate intake should be spread throughout the day to help maintain the blood glucose level. Protein is also important. It is useful for growth and repair of body tissues. The third nursing intervention is glucose monitoring. Nurses usually take blood glucose level before breakfast, before lunch or dinner, 2 hours after meal, before bed, before exercise, and when patient is feeling unwell. As nurses, it is important to keep track on the patient's glucose level, as it can provide critical information for health professionals to determine the best strategies in managing diabetes. By monitoring blood glucose level, this also helps patients in maintaining a stable blood glucose level. And the final treatment I'll be talking about is insulin therapy. It is an injectable treatment for diabetes type 2. Patients often don't have enough education on injection technique, or there can be some barriers towards the treatment, such as denial of the need of insulin, fear of injections, weight gain, and complexities of insulin use. Therefore, it is important that nurses approach, clarify patients' obstacles, and help them overcome it. Ask patients if they understand the requirement and importance of insulin, and reinforce the idea that insulin can help with their condition. Identify any misconception about insulin therapy. Listen to patients' specific concern. Instruct patients with needle anxiety about new technologies, including pen devices and fine-coated needles, to make them more comfortable. Reinforcing patients' role as an active decision maker in her own treatment while offering treatment, help, and support. Before any procedures, nurses should be aware of many things, such as getting consent from patient before every procedure, and infection control can be neglected while caring for diabetes patient, as the high level of glucose in blood and tissues create an advantage environment for bacteria to grow and help infection develop more quickly. As nurses, some of the basic strategies resulting in positive patient outcome are practice and promotion of hand hygiene, consistent use of aseptic technique, patient education, and removal of unnecessary invasive devices. My friend Miro will tell you about the medication for patients with diabetes type 2. Thank you for listening.
Pharmacological interventions can help reduce the symptoms and effects of a high blood glucose level. In our patient's Mary Jane case, her diabetes is under control using oral medications. In the future, she might need insulin therapy if the condition gets worse. Therefore, her glucose monitoring chart should be well documented. Please be aware that insulin is a very dangerous drug. If her condition gets worse, remember to notify the doctor and make sure you double check the 7 rights of drug administration with another nurse before you give your insulin therapy. Along with diabetes medications to help alleviate her diabetes, other medications will also be needed to treat her hypertension, your depression, and the high level of cholesterol. The list of drugs she is on is shown below. First, biguanide, also called the metformin. Metformin improves glycemic control in type 2 diabetes by inhibiting hepatic glucose production, glyconeogenesis, and improving sensitivity of peripheral tissues to insulin. Indication: diabetes type 2. Contraindications: diet-regulated diabetes, biguanide sensitivity, renal failure, acute significant blood loss, sepsis, gangrenous pancreatitis. Precautions are renal dysfunction and hepatic insufficiency. So adverse effects include gastrointestinal upset, erythema, and the dose is 500 milligrams twice a day. Second drug, Alcupro, ACE inhibitor. It lowers blood pressures by inhibiting the activity of enzyme ACE, which reduces the production of angiotensin II. This then causes the blood vessel to dilate and blood pressures fall. Indication, hypertension. Contraindication, angioedema, history, renal insufficiency, hypertensive, congestive heart failure, patients, and pregnancy. Precautions are renal function, monitor blood pressures, collagen, vascular disease, progressive liver disease. Adverse effects, chest, abdominal, and back pain, hypokalemia, hypertension, fatigue, headache, and dizziness. Third drug is the APO atorvastatin. It is a prescription medicine used to lower cholesterol and lower the low-density lipoprotein (LDL) and lowers a person's chance of cardiovascular disease. Indication, hypertension, also for angina and non-fatal myocardial infarction. Contraindication, active liver disease, pregnancy, woman of childbearing potential, unexplained persistent elaborate serum transaminases. Precaution, monitor patient's baseline, blood pressures, muscle weakness, lipid level, stroke, severe obstruction, coronary artery disease, uncontrolled seizures, severe metabolic and endocrine disorder. Adverse effects include peripheral edema, dizziness, headache, fatigue, gastrointestinal upset, and skin rash. Lastly, paracetamol, a simple analgesic and antipyretic, used for pain relief as well as reduce febrile conditions. Indication, analgesic and antipyretic, reduce headache, toothache, muscular ache, arthritis pain. Contraindication, hypersensitivity to paracetamol. Precautions are renal and hepatic dysfunction. Adverse effects include hepatotoxicity and skin rashes. Most importantly, don't forget to check the allergies of the patient.